এই সুদীপ্ত, স্যারের সম্বন্ধে তোমরা অনেক ভালো বলবে। আমি স্যারের কাছে তো ডিরেক্টলি পড়িনি, স্যারকে চিনি। হ্যাঁ, শিওর 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 শিওর।
What is the time? Good afternoon. We are going to start the session, and it is going to be delivered by Dr. Asokananda Konar. He has been an illustrious student of our alma mater, and you can see his name etched in the ALT lecture theatre. Okay? And currently he is a director of gastroenterology and hepatology at Peerless Hospital. He has 4 DNB gastro students under him. So in all he has 12 students really. And we all know him well. And he has been associated with Ramakrishna Mission Hospital doing charitable work. Dr. Konar is going to speak on NFLD. It is an epidemic in the West, and we are soon going to catch it, and we are in fact going to catch it very soon, because as you all know, we are a diabetes capital of the whole world. So Dr. Konar, please.
Thank you, Dr. Todi. I think we are really fortunate and emotional to come back to our alma mater. And it reminds me of my student days. And I remember doing a student seminar when Professor M.K. Chetri was a chairperson. And it was in the GLT. The hall was full with all the, it was a student seminar. So all the students, I know it has been a tradition for the students not to attend any reunion seminars. But those days, I remember the hall was full with people, and mainly the students and some of the faculties, our teachers, and we had a student seminar, and it was attended by the luminaries from our college. Anyway, today when Dr. Sudipto told me, I thought NFLD could be a good topic to discuss. However, I thought the treatment part is rather should be left for the gastroenterologist. I don't think it has become so complicated. One should not be going for treatment of NFLD in a matter of, I think, for a casual discussion. It needs in-depth knowledge of the subject and why are we treating it. I would This is just a slide to show that the liver disease is increasing. This is a data from UK, where it has been shown between 1970 and 2010, but over 40 years, one can see the red line is the mortality from liver disease, where all the other important diseases like ischemic heart disease, cerebrovascular accident, respiratory, everything is declining, the liver disease is increasing. So this is a reminder for all our people that liver disease is a very important one, and we must pay attention to the scenario of death from liver disease. This is again a global burden of disease, where the upper panel is showing the cancer, liver cancer throughout the world, and the lower part is the on cirrhosis. The black one is from NAFLD. South Asia is last but one, where NAFLD and liver cirrhosis is less compared to other parts. And in cancer also, South Asia, one can see the fifth one. There the hepatitis B is the red one, green is the hep C, and yellow is the alcoholic liver disease. So still, the data shows, it is 2017 global burden of disease, so 2022 is not yet out. So we'll know more about the portion of NFLD. So it's an important thing. We remember that prevalence is high, 17 to 33%. And all metabolic association, just to reiterate. I think this slide is important to show that this is between diabetes, metabolic syndrome, and NAFLD. If you have diabetes and metabolic syndrome, there is a high chance of, that is 2 to 6-fold increase in risk for liver fibrosis. And on the other hand, if you have NAFLD, there is a high chance of developing diabetes. This is a study, mainly an epidemiological study from US, published in New England Journal, where they have shown that in US, 25% of the population has NAFLD, of which, again, 25%, that means 5% of adults had NASH and 1% had cirrhosis. Between the East and West, not much of a difference. That is the most important thing about this slide. And this is from China, which NAFLD one can see is increasing, whereas the HBV, the green one, and HCV, the black one, is declining. So even in developing nation, the proportion of NAFLD is rising high. This is the Asian countries. This is our Dr. Ovijit's paper published in 2010, which showed 75% of the NFL has non-obese. So that is a new horizon on that. And it shows the West Bengal, the BMI was around 20, and this is the rest of the world. So this is a study, and this focuses, this is a study published in Lancet, where it shows the globally, the non-obese person is high throughout the world. You can see in the US, 34 to 52% of patients of NAFLD is non-obese. And India also, so it is not that it is just an Asian phenomena. You can see this is a very recent study published in Lancet, where we can see that the non-obese and lean patients are also quite common throughout the world. And I would skip this. And why it happens, there are several explanations, but this is one to summarize that they are obesity resistant. Mainly it is genetic, but there are environmental factors like our bile acids are higher in lean NAFLD and microbiome is different. So histological and clinical outcome has also been checked. I would just point one slide where one can see the BMI when it is less than 25 and between more than 25, one can see the fibrosis in all degrees are much less in non-obese patients. And this is a Kaplan-Meier curve showing the mortality. So key points are, this is not obese can also present in NAFLD. It is present worldwide, and lean patients appear to be most common, still most common in Asian. These factors are there, and I would like to, I think I'll skip the histology. Pathogenesis, in short, I will just touch that the first thought was about the, increased fatty liver is due to insulin resistance, increased plasma-free fatty acids going to the liver, and they're deposited as triglyceride. Then the concept of two-hit hypothesis, that we know the bad storer means there is a second hit in form of lipotoxicity. And it has been, now we know this is a multiple hit hypothesis. There is, number one is the gut. Gut actually has a low-grade inflammation, change in microbiomes, and there is bacterial translocation. Also there is fatty, the adipose tissue inflammation, and liver has to integrate all these and produces what we know as NASH. And bile acids also has an important role in glucose and lipid metabolism. So to summarize everything, that we have a adipose tissue liver axis, the gut liver axis, and also there are genetic factors. Then there are other factors like intestinal dysbiosis, lipotoxicity, 30% will go to NASH. And we know that 75% will probably have low-grade NAFLD, and only about 25% will progress. This is the natural history. We know that it takes about 7 years for progression in one scale for fibrosis. And liver fibrosis has been shown to be the main factor. Here we can see this slide, the green one show non-NASH and non-fibrotic, they live longer. And the red one is NASH with fibrosis. So fibrosis is the only factor, and it can show that, all grades of fibrosis are important for mortality and progression of liver disease. And so nowadays, what we do, actually as a practicing gastroenterologist, are advised to follow. This is a AGA guideline published in 2019, has been revised, that one should do a blood-based test like FIB4. If it is more than 1.3, one should do a second test like FibroScan. And if it is more than 12, it needs attention from the gastroenterologist. This is a recent paper showing that if we have two values like FIB4, along with that, if we do a MRE, which is not always available, then it improves to rule out and rule in fibrosis. And these are the different methods, I think, well known. And MR studies, one can show that before treatment and after treatment, the progression. And one can, this is a correlation between FibroScan and the MR values, and one can see this 8.8 kPa, that is the grade 2 fibrosis in FibroScan, is around 3.3 kPa in MRE. So FibroScan is really, is mostly available to us, and MRE, though accuracy is increased, is not always available. So FIB4 is better than the rest of the blood-based tests. FibroScan is better than FIB4, and MRE is better than. That's the way. But the new way of looking at things is this Veveno thing, that we know that by just doing a liver stiffness measurement, if it is less than 10, you can rule out advanced chronic liver disease. Between 10 and 15, it is, that is compensated advanced chronic liver disease, and LSM more than 15 is to rule in that this is advanced chronic liver disease. And this shows that between 10 and 15, if you have your patient, then they are probably the targets of therapy. If it is less than 10, they don't have a advanced fibrosis, and if it is more than 15, it is almost always advanced fibrosis, and some of them would be in cirrhosis. So I think this is a INASL guideline. They said the FIB4 value has shown that less than 1, but internationally it is 1.3. So I would just suggest that this is one of the essence of approach, that if we have our patient around fibrotic NASH, then they probably will require pharmacological therapy. Lifelong, they will have lifestyle modification, and there is aggressive management when they have advanced fibrosis. And the essence of therapies target obesity, target the metabolic syndrome, target liver disease, and minimize or downstream complications. Lastly, I would like to finish by saying the NAFLD is gradually, the term is becoming obsolete because it's a non-starter, like non-B, non-C hepatitis. We know that non-A, non-B hepatitis. But once we have discovered hepatitis C, that term has gone. Something like that, akin to that, this is the international consensus. People are saying one cannot mark a disease as non-something. It is saying non-alcoholic. But what is it exactly? It is a metabolic associated disease. Hence, they have proposed that hepatic steatosis in adults is detected, and then if you have at least 2 of the metabolic abnormalities, it should be called metabolic dysfunction associated fatty liver disease, which has been changed to metabolic associated steatotic liver disease because of the fatty, it seems, is stigmatizing. So the current term would be MASLD or MAFLD, and which is becoming accepted by most of the societies. And this is my last slide, that any people, it should not be man or woman, presenting with fatty liver, exclude secondary cause. Metabolic association is very important. Cardiovascular risk, because that is one of the important mortality points. Differentiating between NAFL and NASH, that is the most important issue. non-invasive markers are important. We have these special tests, and NFL is basically a lifestyle modification. NASH, there is emerging therapies which is changing every day. And if there is cirrhosis, then I think they should be caring for the HCC and other complications. Thank you.